Peripheral artery disease. Think 65-year-old smoker, diabetes, chronic kidney disease, hypertension, who presents with hip pain as well as leg heaviness. Pulselessness is actually very specific. In 90% of cases, if there's no pulse, you'll have peripheral artery disease. However, no pulse is not very sensitive. There's a wide range, 30 to 70% of people will have a pulse, but that doesn't mean they don't have peripheral artery disease. You can have a pulse with peripheral artery disease given increases in collateral circulation as well as just other bypass vessels that supply the rest of the arteries. You diagnose it with an ankle brachial index. Less than zero point 0.9 is diagnosed as peripheral artery disease. You measure the systolic pressure of the ankles, compare that divided by the brachial pressure. 0.9 to 1.3 is normal. Greater than 1.3 does not mean no peripheral artery disease. Chronic kidney disease and calcium deposits can cause decreased compressibility of the vessels, and the patient can have a high ABI, however, still have peripheral artery disease. You can think of peripheral artery disease very similar to how you would think about a heart attack. These are atherosclerotic conditions affecting the artery, decreasing the blood flow to the organs that it's supplied to. For peripheral artery disease, it's the feet. In the same way you do an EKG for a heart attack, you would do the ankle brachial index for peripheral artery disease to get a good impression of how the blood is flowing to the peripheral arteries. However, you don't just want a static measurement. You want to see how the body is doing with movement. You want to give it some stress. So much the same way you would do for a heart attack, you would do a stress EKG. For peripheral artery disease, you would do a stressed ankle brachial index. And you can see how the blood flow is when the patient is actively moving. For treatment, you can think about cilostazol as one of the first lines. 67% of people will experience improvement, but it takes about 3 to 6 months. However, 67% of individuals will also experience side effects. This means GI symptoms like nausea, some dizziness, some tingling. And these are symptoms that are very concerning, and you can experience it right away. It's very hard to know who will experience these symptoms, and you don't really see the benefits until 3 to 6 months later. So it's really hard to counsel patients to continue to take the medications with the side effect, given that they may or may not improve over time, and it takes 3 to 6 months to figure out. Cilostazol carries a black box warning for individuals with heart failure not to take the medication. Supervised exercise therapy is also very important and helpful in patients with peripheral artery disease. Think about this as exercising your legs, pushing yourself to the limit, going on a treadmill 45 times, 45 minutes a day for more than 3 days a week for roughly 26 weeks. That's how it was studied. When you push yourself, when you get the pain, you rest. So it's kind of like getting up, exercise, pain, rest, exercise, pain, rest. And this cycle promotes angiogenesis, creates collateral circulations, makes new blood vessels, and brings nutrients to the area. This has been shown to help decrease the symptoms of peripheral artery disease, strengthen the muscles, decrease the need for limb amputations. And the trial to cite is the CLEVER trial, where they showed that supervised exercise therapy is as good as endovascular or surgical options for treating peripheral artery disease. A checklist for clinicians to make sure they go over with the patient each time is SALAD. Make sure they go over smoking cessation being the most important, telling the patient to stop smoking, giving them options such as varenicline or buprenorphine to help lower their addiction. Antithrombotics, antiplatelets such as aspirin, Plavix, or Viroxaban is also used too. So NEP2Y12, clopidogrel, Plavix, prasugrel, ticagrelor, those are the P2Y12s, as well as antithrombotics such as rivaroxaban. Rivaroxaban is one of the new and up-and-coming players in the space. Rivaroxaban has been shown in 2 major trials to help decrease heart attack, stroke, cardiovascular death, decrease the amount of limb amputations. One was the COMPASS trial that showed that rivaroxaban is good and can be used for secondary prophylaxis for prevention for individuals with cardiovascular, stroke, as well as polyvascular disease, any atherosclerosis or peripheral artery disease. Rivaroxaban with aspirin does better than aspirin alone. And also, even after you get the endovascular procedure or femoral popliteal bypass, rivaroxaban has been shown to be superior than just aspirin alone for decreasing the rates of heart attack and limb ischemia. So rivaroxaban is very helpful. You might see that on a patient's medications. Lipid-lowering agents such as atorvastatin 40 milligrams to 80 milligrams, as well as rosuvastatin 20 to 40 milligrams has been shown to be helpful. Antihypertensives such as ACE inhibitors have been shown to decrease the rates of limb amputations in patients in this population, as well as diabetic-lowering medications such as the GLPs, the tides, linaglutide, semaglutide, as well as the SGLT2s, canagliflozin, dapagliflozin, and pagliflozin. Canagliflozin used to have a black box warning of limb amputations because it can cause fungal and UTI infections in the area, causing really bad Fournier's gangrene, causing amputation. However, more newer trials have shown that there really hasn't been that much limb amputations, and it's shown to have decreased MI and limb ischemia effects. So the benefits of the drug outweigh the theoretical limb amputation. When these interventions don't work, that's when you start doing the surgical interventions. And these are really used for patients with worrisome symptoms, patients that are unstable, that have wounds that don't heal, they have ulcers that are chronic, they have pain with rest and dry gangrene. That's when you think about surgical approaches such as endovascular repair. You do an imaging of the arteries, and then you can go in with surgery to repair and improve the blood flow to the area, revascularization. And then you can also do femoral popliteal bypass to bypass the area of the stenosis and the peripheral artery disease and revascularize the area below.